This is the orientation for the patient empowerment track in January. It's a brand new track, and the Connectathon is January 13th through the 15th. The name of our track is called Patient Request for Corrections. And this track is brought to you by the Patient Empowerment Work Group. We're a new work group. We were approved this February. We meet every Thursday at 1 p.m. If you want to be on the listserv to get the messages that we're sending to each other, you can sign up here on the left, patients at list.hl7.org. We also have a patient empowerment stream on chat.fire.org. Please feel free to sign up for those. You can get to our homepage. The bit.ly link is the HL7 patients. The co-chairs of this patient empowerment work group are myself. I am Debbie Willis. Dave DeBroncart, who is known affectionately by lots of people as ePatient Dave, and Virginia Lorenzi, who has been a really long time participant in HL7. She's very knowledgeable, and she also works at New York Presbyterian, so she is deep into this and is a great co-chair. So we had lots of requests at the very beginning of what we feel the projects are that we should be working on. And we started with three. Our three current projects are the patient request for corrections to errors in their chart. The leads for that project are myself and Virginia Lorenzi. Our second project is patient contributed data white paper, and Jan and Maria are the leads on those. And then there's advanced directives interoperability, and Maria is working with the PASIO group on that. If you would like to join any of those groups, you can reach out to us. You'll be able to find our information on our patient empowerment home. Happy to have you join. So HL7's vision is that a world in which everyone can securely access and use the right health data when and where they need it. And that's really important. And I share a quote from Dave. The reason we're here, at least doing this track, is that when the right health data arrives, it better be right, or bad things can happen. So let's talk about some of the bad things in the history of bad data going around. So all the way back in 2014, the Wall Street Journal did an article about mistakes in the medical record. And in that article were some interesting quotes, and really they focus mostly on medication. So I'm going to talk mostly on medications here because that's what the quotes were on. 95% of the patients who looked at their data found that their medication lists had mistakes. And 90% of the patients requested changes to their records. And 80% of those were accepted by doctors. So the doctors saw these were very valid requests for changes, and were happy to get those changes and make them. And a doctor from Geisinger said, if we don't have accurate data, we can't take care of patients appropriately. So what we are doing, really, our focus for this project is to make sure that doctors take care of us appropriately, that because with all the correct information. It's really important that they have the correct information. When we first started looking into this, we knew that HIPAA gave us the right to have our records corrected, and so here's our rights in HIPAA. But then there's something else too that we really appreciated, is that the correction principle recognizes that we as patients play an important role in ensuring the integrity of that data. It's not just that, yes, we should have our data correct, but really that we should be very involved in this to make sure that the data is correct. And again, that's why we're while we're doing this. And GDPR, which is the regulations for Europe, also has very, very similar regulations concerning a patient's right to rectification and specific actions that must be done. So we looked at the two, HIPAA and GDPR, because really what we want to do is create a global solution as much as possible. The rights were very, very similar, but HIPAA did something extra, which we were very happy about. They actually had something called implementation specifications. And so what we decided to do is kind of mimic that flow in order to build this new track, this IG implementation guide. We are not telling people what to share. We're simply building the platform to share information. If you have a paper workflow or a very manual process that you're trying to automate, it's really important that you understand the manual process, all the pieces that go with this process, so you can automate it. If you don't understand what's happening now, you might miss some of the pieces and not have a very good solution. And since the pieces, and I'm going to show you that in a moment, the pieces are regulated, at least in HIPAA and in the United States, the pieces are regulated by the government. They say all of these pieces that I'm going to show you are required for a patient to accommodate a patient's request for amendments to their record. So we decided to start with that. And we're not, like I said, we're not telling people what to say. We're just having the platform to accommodate what they're doing right now manually. So really the only difference we found was the covered entity had to respond within 1 month instead of 60 days, and the extension period for the covered entity was 2 months instead of 30 days. So these are the elements that I'm going to show you. These are the elements that we need to consider when we are building this communication workflow. So first, the patient needs to identify where they found the error. And normally we're thinking they're going to be getting their data in a mobile app or something, because there's more. FHIR has empowered that, has empowered patients to pull their data in via FHIR API. So the patient needs to say, well, this is where my error is. It could be a structured element like medications that I showed you before, or it could be something in a note, because now USCDI has broadened what's going to patients, and that's including more notes. And so a patient may notice something in a note that's not correct, and they want that to be fixed. They want to communicate that problem. So the patient identifies not only where the error is, but what they want done, what they want the error to be corrected with. The reason they want the change. Now, some organizations may require that, but it's not part of the HIPAA guidelines, but it is part of some organizations that the patient actually says why they want this done. Another option is who they want notified about this error. That is a legal right of the patient to say, I want these people notified. So the first two things that a organization can respond, they can say, I need more time, or we've accepted your request. And those two actually are quite easy workflows. If the entity needs more time, they need to tell the patient why they need time. And they also need to give them a date of when they will respond back with the accepted or rejected. If they accept the request, the entity needs to notify the patient that it is accepted. And if the patient did not give them a list of who to notify, they need to ask them, do you want us to notify anybody? And then the patient can respond with, yes, these are the people I want you to notify. Now, those are pretty straightforward and easy workflows. Here's the complicated one. So if the entity looks at the chart and says, nah, that's not really accurate, we're going to deny this. they must provide the individual with specific things. Now, again, this is what entities are doing manually by the law. And so we're just trying to accommodate the workflow so they can do this in an automated fashion using FHIR. So they need to be able to speak in plain language and contain the basis for the denial and let the patient know they have a right to submit a disagreement. They have to let the patient know that they can provide the request for amendment and the denial to any future disclosures if the patient wants them to. Even though they're denying it, they can supply whenever they give that information to another entity, they can say, well, this piece was denied and here's the information. They also need to let the patient know how they may complain. So what the next steps are. So the next step, if the patient wants to, they could submit a statement of disagreement. And then the entity can prepare a rebuttal. So these are all the pieces that we want to automate the exchange of information going back and forth. So our ultimate goal with this Connectathon is to eventually have an implementation guide so that this can be used throughout to provide a standard of how a patient can communicate with a covered entity to get their request for corrections. So this particular Connectathon, we've drafted an implementation guide. This is all very, very new. We're going to test a resource called the task resource. We reached out to several groups and several meetings. There were about 3 or 4 different resources that were looked at. The task resource was the one that most people said they felt we needed to try. And so that's what we're trying in January, the flow of information using the task resource. And so the track co-leads for this Connectathon are Virginia, Lorenzi, and myself. We will be testing 3 scenarios. So the first scenario that we're going to test is a really easy one. The patient requests a change and the change is accepted. And at that point, the covered entity makes the requested change, but that is outside the scope. They're doing something in their own organization. But back in the scope is they notify the patient. The next scenario that we're going to test is the patient requests a change, but that change is denied. And so then the covered entity needs to respond with all those elements that I showed you earlier. The third scenario is the patient's disagreement with the denial. And optionally, if you want to test, you can also test the sending of the rebuttal by the covered entity. Now, at this point, I am going to hand it over to Virginia because she's going to be going through the other aspects. Virginia, I think you have keyboard and mouse. Why don't you try it, see if it works. There you go.
There we go. I feel like I'm on the wrong slide though. Okay. Thank you. Okay. I'm having maybe delay issues. 1 second. Okay, good. And welcome everyone. I'm really excited to be here. This was the project that from the when this work group was just an idea. And I remember us sitting at HL7 and just the energy around patients being able to just talk back and respond and request corrections to their data was so much a priority within this work group. So I'm really glad to be here. You know, we have really been thinking about this since the inception of our work group and really got started on our work on this in the early summer. So really quite a lot has happened to get us here today. So I'm really excited. We do have a draft implementation guide. The link for the draft implementation guide is right here, and it really consists of just 2 profiles on the task resource. We have a test plan for this Connectathon to provide structure. It contains 3 scenarios, the scenarios Debbie just listed, but there are, as you could tell from the HIPAA workflow, there are a lot of nuances to this. So there are other things that we could do as well. So we have bonus tests that we've included to do some more experimenting. And so the goal of this Connectathon is, as Debbie mentioned, to see if and how the task resource can work. There are certain fields in tasks that we really, haven't nailed down completely on how they would use, and we just need to test out our theories. So the test script can be downloaded here. Get this link on the slide, and we are going to post both this presentation as well as the recording once it's complete. I have a time lag. Debbie, okay, there we go. Okay, so in our implementation guide, we have 2 actors, simply a correction requester. So we think that would be the patient or someone acting on behalf of the patient who is going to request a correction. And we imagine that patient is going to be requesting that via, an application playing that role. Maybe a patient-facing application would make that request. And then the request would be received by the request fulfiller. And the request fulfiller, we'd imagine, would be a healthcare provider, a clinician provider, could even be a payer. And then they would have a system they were using. Maybe the system is an EHR, maybe it's some medical records ROI system, release of information system, or it could even be, an application that just helps with this workflow. And then the 2 tasks are the patient correction request task, which is used to communicate information about a patient's request for correction and the associated process. What I really like about this is that, we've done all this work to get patients their data on electronic apps. You can use a FHIR API and download your data. But but if you want to, if at 3 a.m. you look at your data, or even a portal and you look at your data and it's wrong, you have to make a phone call, fill out a form, and then there's no way to find out how your request is doing, right? There's no way to track it. If I order a package from Amazon, I can track that package. The purpose of this is also to provide that tracking capability. You can see what's happening on that provider side. Have they looked at my request yet? Have they decided to accept it? Like, what are they up to with this? And have a conversation back and forth. And that's what the task resource can do for us. So we have 2 profiles. One is patient correction request, which is to communicate information about the request for correction. So that is one workflow. And the other workflow, as Debbie mentioned, is this disagreement workflow. So at the point after you've been denied, a patient can then log a formal disagreement. And there's also a workflow with that as well. I just want to, this is just an overview of the implementation guide. There's quite a bit more in the implementation guide. And again, it's just a draft. And I do want to just call out Grace on this call. She is actually, we have a huge quote from her in the beginning of our guide, which I think just really hones in on the purpose of why this guide exists. So really appreciate her work in this field. The patient correction request task profile, some of the key fields is task.4, where you would put in which record is being corrected. Who is asking for the correction is in task.requester. Who is being asked is task.owner. And actually, looking at the HIPAA regulations, that can get pretty formal because from an audit perspective, you need to record things like title and or office. When was the request made? Task.authored on, and we have other time date fields that also might be useful within task. But it's really important to keep track when the task is asked for, because then a timer starts ticking from a regulatory perspective, both from HIPAA and GDPR. and what is this correction that was requested? And that's a really important field. That's task dot description. So at our simplest level, this is just a narrative of what a patient wants corrected. So it can just be in this free text narrative. We're going to use the extension and allow markdown. That where task dot description is going to say, I read the note you wrote about me, and I noticed in the note that you talked about that I was a smoker, and I don't smoke. And so, it's the patient can, and that you can even put in that narrative things that you want to happen, but all of that can be in this description of what you see. Maybe it's 5 things you see wrong in your record. You could put it in there. And I'm just going to jump back for a minute. Task.owner, I just want to remind you, task.owner is who is fulfilling the task. And for example, a healthcare provider, and I just mentioned that in HIPAA, you need to actually provide title and office of the person who is correcting the record or owning
Virginia,
correction.
how do you expect the initiator of the task, if the task is coming from the client, the patient, and they're posting this request to have the record correction made, how are they expected to know who the owner of the task will be at the level? I thought you said you needed the person's name and title and stuff.
Okay, so 2 things, Lisa. All of these fields can be updated by the fulfiller, which we'll get to in a minute, and that's a good point. And also, just from a housekeeping perspective, and Lisa, don't get upset with me about this. We're gonna save the rest of the questions till the end, just so we can get through. But that you made a really good point. So all of these fields can also be updated by the fulfiller, and I would think that would be by the fulfiller. They would identify that. I think on who is being requested, it was just going to be more like, maybe the hospital or doctor name, and you really don't know exactly who you want correcting it. Then there's additional information here. Additional information goes in task.input. In a very simple request, you might not need task.input, especially like kind of our low-tech request. But if you have a sophisticated application that allows you to provide more context on this correction, then you might be able to provide this here. And of course, on the other end, you would need a sophisticated receiver that can take advantage of this. Examples would be the encounter that contain the error. Another example would be attachments, such as an image. We spent some time studying Morgan Gleason's, she provided us with requests that she made for corrections, and she took pictures of her portal and what was wrong and say that this thing looks really funky over here. So you can send pictures in. You might prepare a document that you want to submit as your correction request, and you could do that using a FHIR document. When you're asked who you'd like to notify, or if you want to provide who you'd like to notify, you could of course just do that via a string, but you could also do that by using the communication request resource, which is a more formal structured way to request who to notify. And then we also think inputs can be used to actually identify the specific resources that you'd want corrected, and maybe even the specific corrections that you'd like seen, so corrected resources. This is not an exhaustive list. We think that there might be inputs we are missing. These really need to be worked on. We think that this is something that in the implementation guide needs to end up being a slice. But we're not ready to do, and slice is just a fancy word in FHIR to mean kind of nail down exactly what the input should be and their types, just provide more constraints and structure around that. So we think in this Connectathon, you'll help us figure out what we should be doing with inputs more. So I'm going to move ahead to the fulfiller slide. And again, as Lisa noted, task.owner is an important field on the fulfiller side. But there's some other really important fields. So when you start out a request, the status is really important. So certainly there's a status on the requester side, they're requesting it. But status gets a lot more interesting on the fulfiller side, because this is how a requester can find out what the heck is going on at the provider side. So there are two fields that provide status in the task resource. One is task.status and one is task.business status. And we have spent quite a bit of time thinking about, especially task.status. There is a whole state machine in the task resource, and we've thought about how that state machine maps onto this process, and you'll find more about that in the implementation guide. And we also think that task.status is not enough, and that we need to take advantage of business status as well. We've done some thinking about that and have some of that in the guide. We really have more work to do on that. I noticed on the Zulip chat that Abigail Watson posted some ideas that she had on business status. So this is something that we also hope to think about some, about how we would use statuses in this. And we may not be exercising all the statuses that would be appropriate in this Connectathon track, because we are focusing on these first three scenarios. Of course, we welcome other things to be experimented with. So the other thing is, in addition to the status, is a status reason. So an example of that would be the status might tell me that this request has been denied, but the status reason might provide me information about that denial. And you heard Debbie talk about how it's really important to provide a reason. There's also a field in task called note, and that is used so that the fulfiller can write notes about the work that they're doing on the task. It's transparent. The patients can see it when they poll. But if they want to be providing some notes as they're working on it, we're in review, we're doing this, we're doing that, they want to provide some things. So when a patient does request, they can see things are going on. And it's also good for communication for the people that are actually doing the work. That would go in task.note. But the field we use to officially communicate with the patient from the fulfiller side is task.output. This is, for example, when the task is accepted, a patient is asked to identify who they want informed of the correction. When a task is rejected, we can provide that formal explanation of a rejection, but we can also tell them that a patient can log a formal disagreement. I'm sorry, I find myself throwing on my provider hat instead of my patient hat for a moment there. When I'm saying that, I'm talking like I am the fulfiller. Okay, so that and the way this works is that the patient is able to see these fields and keep track of what is going on as their patient correction request is being worked on. So let's look at the three scenarios for the Connectathon. And these are based on some of our use cases we have in the implementation guide. We actually have another use case in the implementation guide as well. And what we have in the implementation guide is not exhaustive either. So our first scenario, as Debbie mentioned at the beginning, is a patient just makes a request for a correction to the record, and the request is accepted. It's going to use the profile patient correction request. And it starts out on the requester side, where the patient sends a correction request. And then on the fulfiller side, the provider would review that request. Maybe they're going to ask for an extension. Maybe maybe it's an HIM person, they have to reach out to clinicians. I've heard, really interesting war stories, kind of like the request for correction. What the patient sees as wrong is just the symptom. When it's looked at, maybe you find out that when they said this thing was wrong, it's because it's not even their data. It was on the wrong record. And data needs to be moved between records. We need to, be concerned about the possible breaches of wrong information and patient safety issues, do merges and corrections. So it can be really actually a pretty big deal, whatever this correction is. All the more reason why people should request corrections to their records, as Dave mentioned, and Debbie. So then what happens now while this correction request is being worked on is the patient using the API, let's say a patient-facing app API, polls. It was very simplistic. We're just doing polling. We could have done subscription notification, but we're keeping it very simple to start. They just do a poll. So they go ahead and they make a request for the task resource And each time they get the task resource back, they periodically poll, or a patient could press a button and poll again, and they'll see how it's doing. So, you know, if they poll when it's being reviewed, they'll get back a status that says your request is being reviewed. Then later, the provider side confirms the chart is in error and agrees to correct it. Then when the patient polls, they will get back this status that the request has been accepted. They may also be getting back, you have a right to notify others. Who would you like us to notify? And then, you know, this request is corrected. You know, it may not be, you know, and it's going to be passed on whoever can correct the request. And the correction is a legal amendment. So it's often an amendment to a record. I know the certified systems have the ability to add an amendment to a record. And then a patient finally can pull for the status and find out that correction has been completed. Do see this certainly working in conjunction with APIs that already exist. So a patient has an API, maybe they're pulling down their data again and they will see corrected data. However, that works with amendment. Okay, next request. Scenario 2, patient requests a correction to their record and the request is denied. Starts out the same, right? Patient asks, you see something wrong in my record, this looks wrong. They make that correction request. Same review process, but this time it's determined that the record is in fact correct. This is still a really important conversation. This is a really important engagement with the patient. In fact, this whole process is really important because the patient is clearly upset that their record is wrong. So it's a really important conversation. So that we determine that the chart is not an error on the provider side, provide an explanation of why it's determined that it's incorrect, and that is provided back. When the patient does a poll, they realize that their request has been rejected, but they get this response back that will tell them why it's been rejected and are told that they can disagree, and what that disagreement process is. Okay, and again, this same flow uses that same task profile, patient correction request. And finally on to scenario 3, good. Our third scenario is a little bit different. It's patient disagrees with the denial. Again, a workflow. This time we use our other profile, patient correction disagreement. The fields have many of the same purposes, but there are some slight nuances, and one really important one, and I'm going to reiterate that again, is that it points back to the original task of the correction. So the patient would write their formal disagreement to the correction rejection. They would send their disagreement, and their agreement would be reviewed. You know, there's always that chance that the provider will decide, you know, now that I see what you've said, we are going to agree to correct that. Reaching out to different medical records people, they've said that this is not something they've seen. But it would make sense that you could go ahead and go through the correction process. Otherwise, they would confirm we stand by our decision that the chart is not an error. But they do log the disagreement in the chart, and just like with the amendment, they would agree to communicate that with others as asked. And they might choose to provide, sorry, I have a phone going off. They might choose to provide a rebuttal. So you know, a formal rebuttal could be provided back to the patient as well. But on the patient side, they are going to be polling on a regular basis to see about the status of the request. They'll see it's in review. Then they'll see that it has been, that their disagreement's been logged and is standing firm. And so they get back that status. And I just wanted to point out, so if you do look at the disagreement request task profile, you see one notable difference, and there are some others, is task reason reference. Task reason reference actually includes in it that points to the task that was the original request for correction task. So those are the 3 scenarios we're testing. That's just an overview of the guide. You know, I encourage you to look at the guide and read it. It's not all that long. It's just 2 profiles. But it does represent, you know, an opportunity for a patient to really have a voice. Now that they're getting their data, they can actually respond back and say, I think my data is wrong. Can you please correct it? So how do you participate in this Connectathon? I know some people on this call are, you know, Connectathon old timers, part of HL7, but some people are new. So the first thing is you have to actually register for the Connectathon overall. So you would register at this link below on the HL7 site, and there's both a members and a non-members rate, and there's an early bird rate. So if you register before December 31st, that's when it's $100 cheaper. You get it for $150 or $250. After that, it goes up $100. So I encourage you to register by December 31st if you're going to participate, if you can. And then for our individual track, you can sign up at any time. I suggest you sign up today. I do want to point out that at this point, like, no one has signed up. It's just Debbie and I, as far as I know, because we put out, we had a new sign up sheet for this. So if you were planning on being part of the Connectathon, please go on and sign up on that sign up sheet. We also wanted to confirm who was participating. So we need you to do that. So you have the link there, and I'm going to also show you how you can get to that. And again, you can do that, you know, like I said, you can sign up today. And I just want to point out, you know, we don't call, you know, this just our track in the Connectathon. We think we're having our own thon within the Connectathon, as Dave likes to call it. We're having the Correctathon. So also, if you don't download the slides, if you just navigate on our Confluence space to the Fire space, you can navigate to the Connectathon through to Connectathon 26. This is our 26th Connectathon at HL7, and it's the January Connectathon 2021. And you will find out on our particular track, you will find the same link, but you can just use that direct link as well. We have our own prep sessions as we're preparing for the Connectathon. Our prep sessions, we already have been having prep sessions, and several of you have been joining us, and we really appreciate it, including our work group members, because we took over our Thursday call for a while. But our regular meeting that we have for patient corrections happens every Monday at 3 p.m. Eastern. So we have our next 2 calls are January 4th and January 11th, and encourage you to come and participate at those for prep sessions, our next 2 prep sessions. You can use the GoToMeeting for both of those sessions. A little heads up to people who hang out in patient empowerment that we will be switching to Zoom soon, but we are still using GoToMeeting. And then to prepare for the Connectathon in general, I recommend you watch this exciting YouTube video of all the tracks at our Connectathon and very general orientation on December 8th. And then coming up on Tuesday, already passed. On Tuesday, December 15th, there was a more detailed Connectathon prep, and it shows the GoToWebinar, but if you go on there and register, you get the recording. So that's how you would watch the recording to that one. And then coming up on Tuesday, January 12th, is an explanation of how to use HIPAA for Connectathon participants. Very helpful. So I do recommend that if you are participating, that you watch these videos or attend, and everything will be recorded, including January 12th. HIPAA is a really great platform for online events. We've been using it since June in HL7, and really HL7 has gotten very good at using it effectively, but it does help to be oriented so you can get the most out of your Connectathon. And then in the Connectathon itself, the Connectathon runs from, it starts Wednesday at 4 p.m. and it runs through 5:30 on Friday. starts off with a kickoff at 4 p.m. At 5, there's an intro to fire, which might be of interest to some people. And then the actual time that the work is being done, but you can start on work of this today. I mean, you can start before the Connectathon, and during that time, of course, you can work at whatever time you want. We have people on this call, I know, and people participate from Europe, whenever you would like to participate, and we do have some people that might be interested in Asia. And please let me know, let us know if you're going to be participating from other time zones, and we can make sure that we can, be helpful to you with your questions while we are doing this Connectathon. We will plan for that. But right now our plans are a little more Eastern focused, but it goes on 24 hours. If people know me, I'm always up in the middle of the night. So the other thing is there's a wrap-up session between 4 and 4:30. And I will tell you that on Friday, there's wrap-up sessions as well for each individual track, which is of interest to people, especially people observing the Connectathon. That's kind of the most interesting thing to observe. And then there is a virtual happy hour at the end. But this is the schedule for our individual track. We are going to do a kickoff at 6 p.m. on Wednesday. We wanted to give people a chance to go to that orientation as well as to the introduction to fire. And then we will kick off our track. And then we're going to do our track work. And if there's a problem we need to record or whatever, let us know. And then our track work is going to, official times is on Thursday, 9 to 7 on Eastern and 9 to 5 Eastern on Friday. But we're going to do some status check-ins because it's a virtual event, it's just a little different. So you can know that we will definitely be getting together on Zoom at 10 and 2 on both Thursday and Friday. And we have a Connectathon track chat for any time of day or night. That's at the bottom on our Zulip stream. It's already there, so you can start posting on it now. But everything on there, please make it be about this Connectathon track and this test of this IG. And then we have 2 special events that are going to happen at the Connectathon. One is we're going to have an expert guest panel on Thursday, January 14th at 5 p.m. This is a fledgling implementation guide and really important that we understand the problem we're trying to solve. And so we are inviting guests who we think can help us really understand the problem. Grace is one of those guests who has agreed to participate, and I'm very excited, really understands it from a patient advocacy perspective. She's even built a business around this, which I find is very sad, on helping patients correct their data and running after providers and getting them to correct it. So sadly, she really understands this. She makes me choke up because I just think that's just so awful that people have to need that kind of help because of our process, which is why we're all here, right? We want to make the data flow, as well as some people from the provider side, so from a patient and provider perspective and regulatory perspective. So I think that expert panel will be a lot of fun, really good place. Put it later on Thursday, so maybe we play with it a bit. We get some really good questions for them on, what about this, what about that? And, we're all learning on this process, and we're all just curious of how to solve this. And then our report out is going to be Friday, January 15th at 3:30 p.m. And this is where we report out to all Connectathon participants on how the track went. And then we will have a formal kind of report out logged with our track that will be discussed at our working group meeting, etc. And so that leads us to our Q&A. I know a lot of you have put questions in the chat, and we can also unmute you. I just want to bring up the last slide here, which shows you where you can get additional information. All the details on the track, all the other links I've had, you're going to find all of that in our Correctathon track page, which is posted here. Those that are new to HL7, you'll see Confluence on everything. Confluence is the collaboration platform that HL7 uses. If you have more questions, again, there's that chat stream. So it's our Connectathon chat stream, and you can start posting questions there as soon as you want related to this test. And then you can reach out to both Debbie and I directly. So that I want to open up for questions.
So I see a chat that Lisa Nelson put in. It says, will the correction requester update the task to provide information about who to notify if they had not, if that had not been provided when the task was initially created? And the answer to that is yes. They're supposed to. Now remember, we are not dictating the content. We are trying to build the platform to allow that back and forth, but according to the law, that is part of the deal. But that's really outside of our scope. We put all that information there just to show you it's a whole lot more complicated than some people realize. But yes, they can do that and they should do that, but that's outside of our scope.
So we don't have that in the 3 scenarios, but that's one of the bonuses is that you would test update. And so you would do the update of the task and provide, and that would be a really good reason to update the task, is to provide those if they weren't provided in the beginning.
Virginia, if I may, it's Grace.
Hi.
Hi, everyone. First of all, that was a fantastic kickoff and overview. I think you have so many wonderful ideas and it's mapped out quite well. I'm really excited about this. I wanted to share 3 areas that come to mind for everyone to be mindful of that involve the addendum process that I, as an advocate, and many advocates and patients and family members run into quite commonly, that we should be aware of when we're building this out. With respect to medications, where we typically have the most errors, there is a reason that drives medication errors. A lot of it is that there seems to be a standard operating procedure at hospitals and healthcare delivery organizations and practices to defer to the longitudinal pharmacy prescribing records versus what is prescribed and being taken as of recent. For example, if let's say my mom was hospitalized and she's discharged, her discharge papers will include any and every medication she has ever been prescribed, which could be 30 or 40 medications because my mom is a medically complex patient. We need to go through and remove all of those, and often they're not removed. Fortunately, we pay attention, but in situations where people don't, that can be very complicated. It would be easier to have people point out their and confirm their current medications instead of routinely having this process where we're deferring to the longitudinal pharmacy record. So I don't know if you have any thoughts on that. Somehow where this process supersedes the pharmacy records, or a policy to say that once this guide is implemented, this is how we need to handle medications. Does anyone have any thoughts on that?
Well, one thing, Grace, is that what currently happens is just, the work it takes to correct that, right, is very tiring, right?
Mm-hmm.
You didn't correct it, it's there again. So at least this provides a way that you're not in that paper and phone call mode. I think, I think I've mentioned to people that I have found some horrible errors on my record that I have to call up and I don't feel like it. I also think it's kind of cool to show people. Eventually, I'm sure that Dave will beat me into updating my record because of his concern for me. But I think the fact that if we have a way that these requests are actually coming in automated and a patient can respond back and keep on it with these requests, that it will give patients a louder voice. From a provider side, I know one of the problems that I have seen is that I didn't put that in the record, someone else put it in the record. And so and that's something that once a chart is closed, especially inpatient, if chart is closed, it's like even finding the person or someone who can correct that piece of data can be a big deal. Who has the authority to correct it? So I don't know if we can solve that problem, but we probably are going to make the voice of that and that the awareness of that problem much more apparent by doing this. because it'll be easier to make the requests and track, because the tracking is where it gets lost, right?
Mhm.
You know,
Absolutely.
that's why you do it, you know. Did you have
Another,
other, yeah, go ahead.
another area where we run into what a patient or a care partner may flag as an error and is frequently denied when it's submitted is that a diagnosis will be written down or symptoms will be written down in the record to fulfill insurance purposes so that a procedure, imaging, or a test will be covered. I'll give you an example. A patient may have noted that they had jaundice or a yellowing of the skin. This patient has never had this side effect. However, to have an MRI of the liver and the bile duct, they needed to write that in. When the patient later down the road, their care team sees that, well, you already were symptomatic, let's just remove this area that's problematic with the surgery, and the patient says, no, I never had symptoms. It's nearly impossible to correct these situations because they can't remove that diagnosis because it has to line up with the insurance records. This happens quite frequently where things are documented for insurance reimbursement purposes. They're not actually reflected in what the patient is feeling, but they're not going to be acknowledged as an error. I don't know how you address that.
So, and that I think goes beyond the spec, but in that case, do you make sure that a disagreement is logged?
Or having standardized ways of noting that. I mean, when the disagreement is logged, you did say what's the reason for the denial, standardizing what those options are.
Right, and also there's an electronic way of providing the disagreement. This way, at least you don't have to do a paper form. We could automate that.
Perfect. And
Grace,
then
we're not going to automate we're not going to have a standard list of the reason for the denial. It's going to be something, or at least to start off with, that they type in, because the clinic will say why they are denying it. We don't want to restrict it at this point. We really want it to have a flow back and forth, because we're focusing on the flow of the communication back and forth, not necessarily on what is being said, or, you know what I'm saying? It's like we're designing the phone line, not what they're going to be talking about.
okay, great. And
That
then
makes sense?
yep. So then on my last comment then would be regarding flow. Are we specifically focusing on traditional medical records, or would you look at an addendum for radiology? For example, images that were sent for a second opinion and there was a disagreement in the findings.
Anything that you consider a disagreement, you can anything that you think is wrong in your record, you could mention. You could just put it in a narrative. You can attach things and reference things. So yes, anything that you would normally be able to make a request for correction. And would you make that? Who would you make that? Would you make that request to medical records?
No.
Yes.
No, it would.
Request
So there's definitely a triaging component where that would go to radiology.
Okay, but could you go through HIM to get there? Medical records to get there?
You could, but then I guess they could. So I typically would go directly to the source. What happens is if it go to HIM, they may forward it to the not the correct person. It may be denied. If you have tracking, perhaps you can, as a patient, then see where they're sending it or not sending it, or you could request that this does go. There was a question about requesting and how things should flow. As a patient or as an advocate, you could say, I would like this to go to the radiologist or to the pathologist or to billing or to my doctor who prescribed this drug for me.
So just for everyone who is here, because we're getting close to time, this is the kind of feedback we're going to get on our expert panel. And I think there's a lot of this. I know that I just, in my own organization, requests come to many different places. And maybe a benefit of this being implemented will streamline some of that, but that is, its purpose was to just get the data flowing in, and we'll see. I think there's a whole conversation around this that is beyond, the interoperability. But in HL7, we can define the interoperability. I really appreciate that input. We are at 2. I still can stay on, and we're going to note all of your everything you said, Grace. Thank you. Really, any piece of software on the side of where you're going to that's implemented this could do this. It's a lot of how to implement it on the provider side. You know what I'm saying? That's the thing. So the question is that we have any other questions? I will take questions while we have questions. We can stay on for longer, and it'll be in the recording.
There's nothing else in the chat. Lisa and I have been chatting kind of on the side, but as far as anybody that's posted something, there's no other questions.
Okay, is there anything from your conversation with Lisa that we should clarify to everyone?
I think she's saying no. I think that we'll take her specific questions offline later, especially since it is 1 minute past our time.
Okay, sounds good. Okay, thank you very much to everyone who has participated.
Yes, thank you very much. We look forward to seeing you soon. Please sign up if you want to join. We really would like to have as many people here testing this task as we can.
I want to make just one quick closing comment. At the Fire Dev Days in Seattle a year and a half ago, where this work group was literally conceived, the famous patient advocate Sherry Reynolds, known on social media as Cascadia, came and joined us because she lives in the area, and she tweeted afterwards that being present there was like sort of being midwife at a birth, watching something being born. And here we are a year and a half later, and stuff is actually getting built here. And I've got health data nerd goosebumps watching this happen. So thanks to everyone for their participation.
Yes, this is important work.
Okay, bye-bye.
Thank you.
This conference will now be recorded.